my senior colleague or staff, Dr. Ahmad Adam. You can say hi to Dr. James.
Oh, hi, Dr. James. Nice to have you here in Indonesia and to teach and sharing your experience. Thank you very much, Professor James.
Thank you. Nice to meet you, Dr. Adam.
Yeah, he's our neurovascular surgeon in our department. And also Dr. Ferry Bill, you can say hi to Dr. James.
Hello, Dr. James. Nice to see you. I hope we will get knowledge from your lecture this night. Thank you, Dr. Roland.
Thank you, Dr. Ferry. So we're starting now. Good evening, good morning, and good afternoon, everyone. Welcome to the virtual Skullbase series webinar series visiting professor lecture organized by our neurosurgery department at Padjadjaran University, Hasan Sadikin Bandung Hospital in Indonesia. With honor and pride, I introduce our distinguished guest of this webinar, Professor James Keliu. Thank you for being here with us, Dr. James. As a little introduction about our speaker, Dr. James Keliu is a neurosurgeon and director of Cerebrovascular, Skullbase, and Pituitary surgery, professor of neurosurgical surgery and Otolaryngology, head and neck surgery, Department of Neurosurgical Surgery, Rutgers University, New Jersey, Medical School, Newark, USA. Beside his activity as a neurosurgeon, he is also an educator by actively sharing his expertise and experience around the world through the congress and the workshop. Like my first meeting with him at the Skullbase course in Taiwan with Dr. Sebastian Froelich. On this valuable occasion, he will talk about the topic 3060 degree to Skullbase, which is very interesting. We also thank you for the support to our staff, all panelists and colleagues of Indonesia Neurosurgery Society who join us tonight. We have 2 hour lecture for this webinar. The lecture about more or less 1.5 hours and continue by discussion and Q&A about 30 minutes by panelists and participants. Lastly, thank you all participants from Indonesia and also all around the world who join us today. I hope you enjoy this lecture and webinar. Now the time I give to Professor James. Thank you.
Thank you, Dr. Roland. It's certainly an honor to be invited to participate in this Skullbase Visiting Professor Lecture Series. It's I guess it was my first time virtually visiting Indonesia. So thank you again for this kind honor. Let me begin to share my screen here. Can everybody see my screen?
Yes, it's very
okay.
clear, very clear.
Okay, great. So today I'm going to talk about the 360 approach to the skull base and how to master both techniques of microsurgery and endoscopic techniques. I perform both endoscopic and open surgery about close to 50-50 in my practice. I also do a fair number of open vascular surgeries, including bypass, and also non-skull-based brain tumor surgeries like intrinsic tumors and intraventricular surgeries. And I wanted to always give credit to the people who helped me on my journey and my mentors and my teachers over the last 2 decades. And I was trained under William Caldwell at Utah, and I did a skull base and vascular fellowship with Johnny Delishaw. And Taka Fukushima has also been very influential in my development and acquiring skills in microneurosurgery. And I think it's very important with time that we continue to adapt, and with the advancement of technologies and innovations. I was trained traditionally as a microneurosurgeon, open vascular neurosurgeon, And as I began to develop my practice in roughly around 2008, I partnered with my ENT colleague, Dr. Eloy, who's the one of the prominent ENT surgeons in the otolaryngology world. We've been working together for over 10 years now, and it's been a blessing to partner with somebody and to develop the endonasal endoscopic skills. And what I've learned is that, endonasal is just a corridor, and that you must apply the same two-handed bimanual microsurgery techniques in the endonasal smaller working corridor. So you must maintain these principles when you're doing endonasal surgery. So the approaches to the skull base, as you know, from the open perspective, we can get to all parts of the skull base, whether it's anterolateral or lateral or posterolateral skull base. And as you know, the orbitozygomatic approach is still a workhorse for us for the anterior and anterolateral skull base in cavernous sinus surgery. And occasionally we don't use these approaches as much anymore, but the combined craniofacial approaches or transfacial approaches. And of course, we must not forget the transpetrosal approach, which I still think is very useful for a lot of lateral skull base and petroclival lesions. The endonasal approach has been able to get us to many corridors along the sagittal plane, from the cribriform plate all the way down to the craniocervical junction. And of course, with the work from our colleagues in Pittsburgh, they've helped us navigate into the lateral corridors, into the middle fossa and infratemporal fossa space. So the theme of today's lecture will be about, do we take the high road or do we take the low road? Meaning the transcranial route or the endoscopic endonasal route. And I'd like to approach this from an approach selection perspective, keeping in mind that we must be tailors. So we must tailor the individual strategy to the patient, which is largely based on the target location. And we must also know the limits of our exposure to these regions. I'm going to cover mainly the transplanum corridor, transcribiform, transclival, and then some Petrous Apex and infratemporal fossa regions. So we'll start with the transplanum corridor, and this is the region of the suprasellar area where the optic chiasm and the region above the pituitary gland and retrochiasmatic space is generally located. And the lesions that we generally deal with in this area are largely craniopharyngiomas and tuberculum celli meningiomas. And we recently published this paper on our approach to craniopharyngiomas that I'll reference to, using a personalized, tailored approach. And this is one of my earliest cases of craniopharyngioma, and this is before I had learned how to do endonasal endoscopic surgery. And I did this through a Transylvian orbitopterional approach, and you can see upon the initial exposure, you don't really see the tumor because this is a prefixed chiasm. And in order to expose this tumor properly, you have to open up the lamina terminalis to see this tumor because it's retrochiasmatic. And you have to work between these narrow corridors between the optical carotid triangle and carotid oculomotor triangle. So it makes the surgery very difficult because there's a lot of manipulation between these narrow neurovascular structures. And I can tell you that I did a very subtotal removal. It was very difficult in this location. And so I slowly evolved to doing these from a midline approach. So this is a transbasal exposure. You can see that when you open up the lamina terminalis from a midline transbasal exposure, you have a more symmetrical exposure to both walls of the third ventricle, whereas from a anterolateral approach, you have a great visualization of the contralateral wall of the third ventricle, but the area that's on the ipsilateral side is often a blind spot. So here's an example of a large craniopharyngioma. I like to look at the sagittal T2 images and look for the region of the pituitary gland, which is right here, And then I look for the optic chiasm, which I highlighted in yellow. So if you look at the window of corridor, infrachiasmatic below the chiasm, it's rather narrow. And the tumor does not present itself very nicely to this infrachiasmatic space. Whereas this window between the ACOM and the lamina terminalis is slightly bigger. So for this reason, I decided to choose a transbasal subfrontal interhemispheric approach. This is the standard bicoronal incision in the transbasal approach. And you can see that we're opening up the lamina terminalis sharply here with an 11 blade. And then we'll access the tumor in the third ventricle. So we can now slowly peel the tumor away from the ependymal walls. And once the tumor is freed from both walls, we can deliver the tumor. Here's both walls of the ependyma. There's the basilar artery, and that's the final removal. And you can see that this is a nice approach coming from midline, but the limitations are this area under the chiasm. This is still an area that is difficult to see because there can be microscopic tumor under this area of the chiasm. And you can see the initial post-op removal looks very favorable. I was very happy with the removal. The patient did very well. But you can see about 3-4 years later, the patient developed a recurrence underneath this area of the blind spot under the chiasm. So this patient went on to get radiotherapy, and the tumor has been controlled for the last 10 years. So why is the EEA favorable for this retrochiasmatic location? This is the view from above. This is the view from below. And I think the major advantage from endonasal approach is this ability to look at the blind spot, the ability to look at this undersurface of the chiasm, the small perforators, and to directly see the hypothalamus. So let's take, for example, this craniopharyngioma. This patient presented with an acute headache to the emergency room. If you look carefully here on the imaging, this is the diaphragm. This is the tumor in green, and this is the normal gland in yellow. So it's very important that you don't choose a transcellular corridor, but you expand it to the transplanum transtuberculum corridor to adequately access this tumor. I've seen various colleagues who make the mistake of just opening the cella thinking they can access this tumor only to biopsy the normal gland. So study the imaging carefully and remember that if this tumor is above the diaphragm, you have to go a transplanum transtuberculum. This is our standard setup for most endonasal cases. We try to keep the head in neutral position to the spine. I always prepare a fascial allograft as well as a fat graft. And for transplanum surgeries, we will typically use a lumbar drain, and we'll stand on the patient's right side with my ENT colleague. We typically like to use a 30-degree angled endoscope looking upwards. The 30-degree endoscope is very versatile because it allows you an extra 30 degrees favored angle, and you can rotate the scope so that you can look lateral into the lateral regions of the cavernous sinus, but also look inferior if you have to look below the dorsum sella or into the clivus, and of course upwards into the suprasellar space. There is some learning curve in using the 30-degree angled endoscope, but it does provide a lot of advantages. So if you're using the 30-degree scope, you have to remember that if you are looking upwards, you have to put the scope position in the 6 o'clock position of the nostril and your instrumentation in the 12 o'clock position. This is how you avoid sword fighting with your ENT colleague. And of course, if you're right-handed, you can put your drill or dissector instruments all in the left nostril. A technical point about the transplanum opening. When you're opening this area, I typically will follow the course of the optic nerve canal. And if you know the optic nerve canal course, it goes anterolateral from a posterior to anterior fashion. It goes slightly more anterolateral. So if you follow the course of the optic nerve canal and drill the planum, it's not a rectangular shape, but it's actually a trapezoidal shape of bone opening. And some people have published this as a chef's hat. So it looks kind of like a chef's hat upside down. But this is important when you're doing tuberculum meningioma surgery, because about 80% of these tumors will have optic nerve canal invasion, and I believe in early decompression of the optic nerve canal, and I'll discuss that a little bit later. Thank you for muting the microphone. So after we've made the transplanum opening, you can see here's the planum dura. You have to skeletonize and unroof the tuberculum sellae bone, and I always open the bone over the sella turcica, because this gives you control above and below the intercavernous sinus. Sometimes you have to open this area to get more access to the tumor. So when you open the dura, you want to always make sure that you always look for the branch that comes off the medial aspect of the ICA. This first branch that you see here is a branch of the superior hypophyseal artery, and there will be a branch that will feed the chiasm, and then a branch that feeds the pituitary stalk. So it's imperative that you preserve these perforators when you're working on the undersurface of the chiasm, because if you coagulate these vessels or injure these vessels, you have a high risk of postoperative blindness. So it's very important you identify these, and I can show you some tricks on how to preserve these. Generally, there's a veil of arachnoid that covers this tumor. So if you could preserve that veil of arachnoid, think of it like a curtain. You can make an opening in the arachnoid and then move the arachnoid towards the chiasm, kind of like you're opening a curtain and preserving these perforators, so you work directly on the tumor capsule. And this is a principle I learned from my teacher, Dr. Peter Carmel. He taught me that there's two layers of arachnoid, a cisternal layer of arachnoid and a tumor layer of arachnoid. And you want to work between the layer of the tumor arachnoid and the tumor capsule itself. So if this is the tumor, you want to mobilize the arachnoid towards the sides of the neurovascular structures. So look at the ICA here. You notice how the ICA is covered with the two layers of arachnoid. And this arachnoid layer is a very protective veil or a protective curtain, and it keeps the PCOM and the P1 perforators intact. So when you're working towards the back near the basilar artery, those P1 perforators can have a form of protection. In most cases, craniopharyngiomas will respect the membrane of Lilliquist. So if you find the membrane of Lilliquist, this is that same layer of arachnoid that you want to work between the tumor capsule and the tumor arachnoid. So if you preserve the Lilliquist membrane, you'll protect the basilar artery and those P1 perforators. How do you find the pituitary stalk? I think the easiest way is if you find the normal gland and you find the inferior margin of the tumor, when you gently lift the tumor up, look for the portal striations. These portal striations, which look like stripes, are the vessels that are on the pituitary stalk. And in some cases, if you see this, you have a chance of preserving the stalk. And this is one case where we're preserving the stalk, and here's the basilar artery. Notice the Lilliquist membrane covering the basilar artery. And of course, in some cases, you cannot preserve the stalk because the tumor sometimes, what has been described as a type 2 transinfundibular type of craniopharyngioma, these tumors will expand the stalk and often invade the stalk. And it's actually better to transect the stalk at the base than to try to preserve it and have residual tumor. And these patients can be managed very successfully with hormone replacement therapy. So this is an example of a type 2 transinfundibular. So here's the craniopharyngioma. This is a tumor. This one was very adherent to the undersurface of the chiasm. Here's the mammillary bodies. And we're dissecting this cystic tumor capsule off of the undersurface of the chiasm. See, this view would be virtually impossible with a transcranial approach. And look how adherent this cyst wall is. I I feel that cystic tumors sometimes can be more challenging and more difficult because now you're working with a collapsed balloon instead of a firm ball. So the resistance of dissection and counter dissection is more difficult. This tumor has completely invaded the stalk. So in this case, we have to transect the stalk at the base in order to deliver this tumor. And you can see here's the final dissection of this cyst wall from the undersurface of the chiasm. And then we'll amputate the last bit of attachment. This area was very adherent, this remnant. So I didn't want to impair her vision. So I just transected. I leave a small little residual. And this is the tumor being removed. She did very well for about 4 years and then developed a recurrence, most likely where I left that residual. So I had to go back and do a repeat debulking, and then I sent her for radiation. So since then, I've changed my paradigm. If I know that I've left a little microscopic residual, I will not wait for recurrence. I will send them to radiation therapy in about 2 or 3 months after surgery to minimize the risk of recurrence. The other major advantage is that these tumors are often adherent to the walls of the hypothalamus. And with this endoscopic view, you can actually have a better view of the hypothalamus. So you can carefully dissect these tumors from their adherents. And then once the tumor has been completely freed, you can deliver the tumor. So always resist the temptation to pull on the tumor prematurely until you have inspected all of the tumor in 360 degrees to ensure that there is no tumor adherence. And this is the final view. Here's the mammillary bodies, the cerebral aqueduct, and this is the basilar artery. And here's the nice view of the third ventricle, the foramen of Monro, chori plexus. And here's the hypothalamus. This is very typical to see the petechiae of where the tumor was adherent. And this is a very standard view of what the removal looks like. So reconstruction is always a challenge because now you have a large cistern of the third ventricle communicating with the nasal cavity. So you must do a good reconstruction. There's many ways to do this, and our preference has been to do a double layer of fascia lata as an overlay, followed by a nasoseptal flap. And here's a video demonstration of this. This is a large defect, transplanum, after craniopharyngeal surgery. And so we'll repair this with a layer of fascia lata with a little Surgicel to hold the fascia lata in place. This is a second layer of fascia lata with the Surgicel. And before you rotate the flap, you want to make sure there's no seepage of CSF, because if you start to see seepage of CSF, the flap will not stick very well. So one of the tricks you can do is you can let off some fluid off the CSF, or you can put the head in reverse Trendelenburg to lower the CSF pressure. And you want to make sure the flap makes perfect contact with all of the bone of the skull base and that there is no mucosa on the bone. Because if there's any intervening mucosa, it will increase the risk of the flap dehiscing from the skull base and getting a flap repair failure. So we'll bolster it with Surgicel, gentamicin, gel foam pledgets, and an inflatable mirror cell packing. We leave the mirror cell packing for roughly about 10 to 12 days. And we'll leave the lumbar drain in for roughly 3 to 5 days, draining at about 5 cc's an hour. So here's the post-operative scan. You can see complete removal. There is no edema on the hypothalamus. So I think this is one major advantage of the endonasal, is that we have better care of the hypothalamic adhesions as well as those vascular perforators under the chiasm. Here's an example of a 12-year-old boy who had visual loss, panhypopituitarism. We're opening the dura along the planum and underneath the intercavernous sinus in the sella, so we can coagulate it with a pistol grip bipolar to coagulate the intercavernous sinus. We cut the sinus through the diaphragm macella, and you get this exposure into the suprasellar space. So we're going to debulk the tumor initially. This is with a side cutting aspirator. And what this does is this allows us to start to collapse the tumor so we can perform extracapsular dissection. So it's very important to debulk the tumor first. Here's the chiasm coming into view. And then this is a suction dissection technique where you put a little gentle traction on the tumor. And then with your suction, very gently, you can use it as a dissector, and we'll slowly peel the tumor away from the walls of the hypothalamus. We'll then lift up the tumor here above the gland, and this one was a type 2 transinfundibular. You don't see the stalk, but we'll carefully peel it from the attachments, and once the attachments are completely free, you can now slowly deliver the tumor from the cavity. So remember to resist the temptation of early pulling. Make sure it's completely free before you deliver the tumor. Here's the tumor being delivered. And now we have this spectacular view of the third ventricle. Now I'm using a 30-degree scope. So now we can rotate the scope. You'll see the advantage of rotating the scope. Follow the arrow. See the arrow at 2 o'clock. We're going to rotate the arrow to 3 o'clock, looking laterally on the left side. We will see the ICA. This is the ICA coming out of the distal dural ring. Ophthalmic artery will be here. And then as we rotate it down, this is the pulsations of the membrane of Lilliquist. Here's the basilar apex, mammillary bodies, hypothalamus with the little petechiae. This is normal. And we'll do our repair with our double layered fascia lata and the nasoseptal flap. This patient had a terrific outcome. You can see the optic chiasm has been nicely decompressed, and the patient has been recurrence-free for about 7 years. So what about if patients have had previous craniotomy? Can EEA have a role when there's tumor recurrence if they've had previous craniotomy? Look at this patient here who's had multiple recurrences. She's had 3 previous craniotomies, 1 microscopic transsphenoidal, and in one of these previous surgeries, she encountered a right ICA injury that resulted in occlusion, and she's blind in the right eye. So this is not an uncommon scenario in a patient who's had multiple surgeries at other institutions. They now come to your practice with this problem, and what do? Do you come from above or do you come from below? Do you radiate this? Do we put a catheter and put bleomycin or P32 for this kind of cyst? She's already had multiple surgeries, so this is a very challenging case. In this situation, I decided to come endonasal. The reason is because look at the cyst wall here. The cyst presents itself to the nasal cavity, so it seems like a very simple solution. So what we'll do is we'll come in endonasally, we'll harvest a nasoseptal flap up front, and we open the cyst and drain the fluid, but this cyst wall is very thick. Look how thick this cyst wall is. One possibility is just to leave the cyst wall open and let it drain into the nose, but I decided to inspect the cyst wall, and I was able to develop a plane here. Luckily, I used this curved dissecting instrument, and I was able to develop a plane. And notice how the cyst wall is like a rubber ball. It's very thick. Here's the left optic nerve. This is the only remaining optic nerve she has. Remember, she is blind in the right eye. The right optic nerve is now atrophied. You don't even see it. And I got a 99% removal. I had a little small residual in the right cavernous sinus that was very stuck, and every time I tried to pull on it, it was bleeding a little bit. So I left a little small microscopic, and then we repaired her with this large nasoseptal flap with a little bit of fascial autograft that you saw earlier. So here's her post-op scan. Again, there was a little microscopic residual in the right cavernous sinus. Because she had multiple recurrences, I treated her with radiation, and she's been recurrence-free for 8 years. So a very successful strategy here. Here's another difficult case. This was a patient who came in with altered mental status. and visual loss. So you can see the visual loss is from this solid retrochiasmatic component. The altered mental status is from this large cyst causing mass effect and shift on the ventricles. So how do you approach this? I debated with myself whether I should come in endonasally or transcranially or both. And I think what I eventually decided on was I was going to stage this. I was going to come in endonasally first because I felt that this would give me the best chance of looking under the chiasm and debulking her from a retrochiasmatic standpoint. And then if I needed to, I can always come in at a second stage from above, from a transfrontal, to remove the remaining cyst. So that was my initial strategy. So we'll come in stage 1. This is removing the planum, the tuberculum eggshell fashion. This is the trapezoidal bone removal. You can see the optic canals on both sides. So we'll open up the cyst wall and you can see the cystic fluid. This is the fluid from the cyst that's coming out already. And then we'll start to debulk the tumor, removing some of this solid component within the cyst. And now we'll start to dissect around the tumor in an extracapsular fashion. Now look at these perforators. These are the small perforators I mentioned that come off of the ICA. You must preserve these perforators. These are not vascular feeders to the tumor, but rather vascular feeders going towards the chiasm. So here's the right optic nerve. We've identified the right optic nerve. We'll further debulk the tumor. And now here's the vascular perforators. It's going around the tumor. Here's the PCOM. And now we're going to look for the stalk. So see how I lift the tumor from the normal gland and I look for the portal striations. Here's the portal striations of the stalk. And then we start to use our microsurgery technique. This is two-handed bimanual microdissection, much like you would do open surgery to lyse arachnoid adhesions. There's the stalk. And now we're going to look above the other part of the tumor. So this is interesting here. Look at this observation. This tumor, you will see, is wrapped around the right optic nerve, almost in a 270-degree fashion. Look at the ACOM complex. Here's the tumor wrapped around the nerve. You can see the right optic nerve is partially encased by this tumor capsule. So I have to free this area. This is the recurrent artery of Hübner. You don't want to damage this. So I incise the tumor capsule here to free up the right optic nerve. Now I can start to work under the chiasm. And here's the ACOM. It's completely encased by the cyst wall. So at this point, I know that I cannot remove this tumor completely. I'm not going to be able to achieve a gross total removal. So in this situation, I'm going to do a maximal safe near total resection and try to preserve the stalk. Because if I cut the stalk, I'm still not going to get a total removal. So why not try to preserve the stalk in this case? So we'll use sharp dissection. We'll dissect the tumor from the hypothalamus. Here's the stalk. Here's the last remaining attachment. And we'll lift up here, lift up the membrane of Liliquis. Here's where we'll see the basilar artery. There's the basilar artery, basilar apex. Here's the chiasm that's now freed. And so once we cut the remaining attachments, we can start to remove this last part of the tumor. And this is the tumor being removed. And this is the final view. This is the frontal cyst wall. It's too far to reach and it's too adherent to the frontal lobe. So it's very dangerous to remove from an endonasal perspective. Look how it's encasing the ACOM. So I think this is the safest removal to perform endonasally. And at this point, we're going to stop and do the repair. This is the immediate post-op scan. Notice how the cyst wall has collapsed. Her vision was intact and she had normal pituitary function with just transient DI. And this is her 3 months post-op. So notice how the cyst wall has collapsed even further. And at this point, this is when I decided that I'm going to irradiate her. Instead of coming in for a second transcranial surgery, I'm just going to treat this last residual with radiation, because even with transcranial surgery, I know that this cyst wall is encasing the ACOM and it's going to be very risky to remove. But look at her 16 months after radiation. The cyst wall has almost nearly completely regressed, and she's had a very nice favorable outcome using this type of strategy of maximal resection followed by radiation therapy. So when is the open approach necessary? When you have a craniopharyngioma that extends laterally like this into the sylvian fissure, this makes more sense to come in with an open approach. And in these cases, I prefer an orbitopterional or modified one-piece orbitozygomatic approach. And you get this beautiful view. This is working in the carotid oculomotor triangle. Here's the ICA, here's the third nerve, here's P2. Notice how you can have a great access to the basilar artery and SCA. Here we achieved a near total removal. There was some adherence to the optic nerve, and so we treated the remainder with radiation therapy. Here's another example of this giant multi-compartmental tumor. This is encasing the A3 complex. So whenever there's also lateral extension into the proximal sylvian fissure. So when there is vascular encasement, I think it's always safer to go open approach than endonasal, because if you have a vascular injury, when the head is open, it's much easier to put on temporary clips and do vascular repair or bypass techniques than it is endonasal. So in this case, we come in transbasal interhemispheric. Notice how these A3 vessels are completely encased by the cyst wall. And then we came in translamina terminalis to debulk some of this tumor in the third ventricle. So we achieved a near total removal, about 95% removal. And at 3 months after surgery, she came back to the emergency room with this cystic recurrence. This is the tumor that was in the lamina terminalis that we tried to debulk. So now you're left with this recurrence. So in this case, since this is primarily retrochiasmatic, we come in second stage endonasal, and we can remove this tumor that's under the chiasm. And then this is calcium. Whenever I see calcium stuck to the chiasm, I always leave it, because if you try to take this, you'll probably blind the patient. And here's the view of the third ventricle. And here she is 2 years post-op. We treated the remainder with radiation therapy, and she's been recurrence-free for roughly 5 years now. Here's another difficult situation. This patient is 80 years old. She's had a previous left pterional craniotomy at another institution that left her blind in the left eye from that surgery. And she did not get radiation yet. So now she has a recurrence, and it's starting to develop this cystic cavity. She was treated by another surgeon who put an Ommaya catheter into the cyst to aspirate, and eventually the catheter occluded. And so the cyst continues to grow now. So now you're left with this problem. So I debated whether I should come in endonasal for this or come in transcranial from the right side. Now she only has one vision left in the right eye, so I cannot impair it. But I know that because she's had multiple surgeries, I'm probably not going to get a complete removal because of scar tissue. And I didn't want to send her to radiation up front. So I thought, what would be the easiest solution to do a minimally invasive surgery where she has quick wound healing, and then I can do early radiation therapy. So if I go endonasal, I have to wait maybe 3 months for the nasal septal flap to heal in order to begin radiation therapy. However, if I decide to do this through an eyebrow incision, I don't have to worry about CSF leak through the nose, and I can send her to radiation therapy in roughly as early as 3 weeks after surgery. So this is what we ended up doing. You can see this is a transciliary supraorbital craniotomy, small craniotomy, a little over between 3 to 4 centimeters. And you can come in transcortically and subfrontally. So we decided to go in transcortically through the frontal lobe to directly get to the cyst wall. So now we can see the cyst wall and separate it from the white matter. And then once we collapse the cyst wall, you want to work in the subfrontal space. So now we're going to go subfrontal. This is the right optic nerve. And then we'll open up the arachnoid here. Here's the tumor coming into view. This tumor has had a lot of dense arachnoid adhesions because of the scar tissue. So you have to use good micro scissors. And we did a lot of scissor debulking. This tumor is very calcified. You have to have good micro scissors to debulk this tumor. And one thing I like to use when you're doing these cases is a good arachnoid knife. And I typically will use a arachnoid knife made by Apex. It's the AM22. It's got a sharp side to the arachnoid knife, but you can use it as a dissector. And I'll show you this in a moment, because this is how I was able to find the optic chiasm. So here's this arachnoid knife. This tumor is pushing on this nerve, and if I cut right on the tumor capsule, it will release the dense arachnoid from the tumor capsule and release it and let it fall towards the normal nerve. This is how I'm able to find the normal nerve without touching the nerve. This is a no-touch technique to the optic nerve using this very nice arachnoid knife. So I find that plane and I just use this arachnoid knife as a dissector. And this is a great way to get the scar tissue off of the neurovascular structures, and then proceed with your micro scissors to remove the rest of this tumor. And then there's the chiasm. Here's the contralateral optic nerve. And then we can now communicate the subfrontal cavity with the transcortical cavity. So now I know I've achieved a gross total removal of the tumor. I suspect there might be some microscopic residual since this is a tumor recurrence. So I treated her with radiation therapy in roughly 3 weeks after surgery, and she's had a very spectacular outcome, neurologically intact, 80-year-old woman. So I was very happy with this eyebrow technique. So remember to use this eyebrow approach in your armamentarium. Let's move the topic towards tuberculum celli meningiomas. This is an area that's still an area of controversy, but I think with proper patient selection, some of these tumors will be favorable for endonasal surgery, and some of these tumors will be more favorable for transcranial surgery. So here you can see we're drilling the optic nerve canal. You have to use eggshell technique with a high-speed diamond burr with lots of irrigation. And then I don't use kerosene rongeur. You have to eggshell it and use an up-angled curette to elevate the bone away from the planum and away from the optic nerves. And the advantage here is that if you do this, you can coagulate the dura early and get early devascularization of the tumor. And then you open the dura, and then you'll see immediately the tumor. It's already devascularized. And so I always recommend debulking the tumor before you try to mobilize the tumor, because you don't want to injure the optic nerves. And now we'll start to come around the tumor in an extracapsular fashion. Here's some frontal polar artery with arachnoid adhesions to the tumor. You must divide with sharp dissection. And here is the left optic nerve. This is the left ICA. And being a right-handed surgeon, I like to come counterclockwise and come above the tumor. Now, again, you must resist the temptation to pull the tumor. It looks like it's ready to be delivered, but look how it's attached to the diaphragm and the cavernous sinus or intercavernous sinus here. So you don't want to pull on this and get all this venous bleeding. You have to inspect Carefully coagulate and sharply divide before you deliver the tumor safely. So again, resist the temptation of early pulling. This is the optic chiasm and ACOM complex. And because I've already unroofed the bony canal, I don't have to drill. I just have to use inspection with a blunt angled hook. Inspect both optic nerve canals. There's no tumor there. And then we'll repair with fascia lata and nasoseptal flap. So here's the post-op complete removal. And here's another tumor. This is a 62-year-old female with unilateral visual loss. Now, when you have a patient with unilateral visual loss, you have to think about optic nerve canal invasion. Now, if we look at this tumor, it's actually a much bigger tumor. It's suprasellar above the gland, and there is no vascular encasement. Now, people talk about the cortical cuff in the literature. Now, remember, all tuberculum cellular meningiomas never have a cortical cuff because the location of the tumor, when they grow, they're almost always going to have the A2s touching the top of the tumor. So cortical cuff only applies to olfactory groove meningiomas. So hopefully that principle is clear. The other concern that people have about TSM is lateral location to the carotid artery. So if you look at the carotid artery here, notice how there's lateral location. Now, I think lateral location is not a complete contraindication. It's only if it's lateral location, but then it comes to encircle the carotid in a 270-degree fashion. Here it goes lateral, but it's still above the meridian of the equator of the carotid artery. You understand what I'm saying? If this is the equator, it goes lateral, but it's not encircling. It's still above the equator. So I think in this case, if you do a good debulking and collapse the tumor, you can still do this safely through endonasal approach. So here's the tumor debulking. We'll deliver the tumor. And in this case, you have to inspect the optic nerve canal, and you can open up the dural sheath like the way you open up the dural sheath in a orbital craniotomy approach. The dural sheath is like, it's like the sleeve of your shirt, a shirt sleeve, and you want to open up that shirt sleeve to inspect for any constriction of the nerve. And here you see there's tumor right here in the nerve canal, and you must preserve the ophthalmic artery and not injure it when you're doing this approach. So here's the final removal and complete resection on the MRI scan. And she went home on postoperative day 2, and her vision went back to normal on post-op day 1. So remember, unilateral visual loss probably means optic canal invasion. So what are our limitations of EEA? Certainly what I look for is lateral extension of the tumor. If the tumor extension goes above the optic nerve canal or over the clinoid, this is better done through open approach because you're going to have incomplete removal with a higher rate of recurrence. Certainly TSMs endonasal have a higher risk of CSF leak. So if you have pre-existing hydrocephalus, don't do an endonasal approach because you're going to have high CSF pressures pushing your graft repair out. You probably have a higher rate of CSF leak. And of course, vascular encasement, as you see here, safer to do with an open approach in case you have to do open vascular repair. So here's a case, a larger tumor. Notice how this one has some vascular encasement, but also lateral extension past the carotid. So this I did through an open approach. This was an anterolateral approach here. You could see we do early bony unroofing of the optic nerve canal and cutting the falciform ligament. So this decompresses the optic nerve early. And I believe in early optic nerve decompression. There's good literature to support that. And then after debulking the tumor, you move the tumor away from the optic nerve. Again, this is a no-touch technique to the optic nerve. We're going to move the tumor away from the optic nerve. And here's the pituitary stalk. Behind the tumor will always be the pituitary stalk. Remember to look for the portal striations. And then as you follow the curve of the chiasm towards the contralateral optic nerve, always look for the contralateral ICA. It will be inframedial to the optic nerve. And then once the tumor is completely detached, you can remove it safely. And there's the basilar artery, basilar apex. Always nice to see the basilar. And of course, the endoscope is not only for the nose. You can still use the endoscope transcranially with endoscopic assistance. And I always use this to inspect for any kind of tumor residual. And she had a complete tumor removal, and her vision was completely restored. So this was a nice result for this patient. So here's my paradigm for TSMs. I generally reserve EEA for smaller to medium-sized tumors that are strictly midline with no to little lateral extension and no vessel encasement. The open approach I reserve for larger tumors that have lateral extension, some hydrocephalus, and of course, vascular encasement as well. So let's talk about the next corridor, the transcribiform corridor. This is generally for sinonasal malignancies and olfactory groove meningiomas. Here's an example of an esthesioneuroblastoma. You can see when there's minimal intracranial extension, these are very favorable for endonasal transcribiform approach. But what about when the tumor invades the orbit and gives you orbital proptosis, as in this case of an adenoid cystic carcinoma? In the past, we would do these transfacial approaches with en bloc removal of the eye and the maxilla. I think the trend has been shifting away from this invasive approach, but to try to preserve quality of life. And we've shied away from this en bloc principle, which has been a principle for cancer surgery for many decades. But we can now do this endonasally, and I still think we get very good survival rates for these sinonasal cancers. Here we're opening up the maxillary sinus. This is the opening of the medial maxillectomy, and then we'll follow the tumor into the ethmoid cavity with an up-angled 30-degree scope. And when we're doing transcribiform surgery, you must do a draft 3 or a modified Lothrop technique. And then you must do a superior septectomy, so you have binostril access to both cavities. This is the drilling of the posterior table of the frontal sinus. This is frontal sinus sinus surgery, and we'll drill the cribiform plate. Here's the posterior table of the frontal sinus. And then when we open up the dura, we open up the lateral sides first in a longitudinal fashion. Then we'll open up the dura anteriorly. And then you cut the falx cerebri from an anterior to posterior fashion. So you mobilize the cribiform like a trap door from front to back. And then you can find the planum dura and cut across the planum dura transversely. And you have this rectangular cut of the skull-base dura, inspect the frontal lobe. And then the repair that we generally do is a 3-layered, triple-layered reconstruction. We do fascia lata for the first layer, and then a alloderm type gasket using an alloderm technique. And then don't forget there's tumor in the orbit. So we purposely reserve the tumor of the orbit last, because when you remove the tumor of the orbit, all the orbital fat will now come in your way, and it will prevent you from drilling the skull base. So we always like to do the orbital tumor last, and then you resect the last part of the orbit, and then we'll put the nasal septal flap back on for repair. This patient is now roughly, I think, 7 years post-op now, and nice reconstruction with no recurrence at 7 years, and he's still alive and well. Olfactory groove meningiomas, this is an area of debate as well. I think there's limited role for olfactory groove meningiomas. Most people say generally 4 centimeters or less. This was right on the border of 4 centimeters, but in the absence of any vascular encasement, we felt this was reasonable to do endonasally. So here's the tumor removal. Here's a large defect. It goes from the frontal bone all the way to the sella. Very challenging repair. So how do we repair this successfully? You can see this is the post-op scan, complete removal. So we developed a triple layered repair. We've published this technique originally, and then we recently published the results of our series using this repair in Acta Neurosurgica last month. But we initially started off using fascia lata as an inlay. Then with the alloderm, we have this combined outer lay and inlay technique where you wedge gel foam. So you get a combined inlay and overlay. This is a technique that was developed by Dr. Casiano in Miami. And then the last layer is the nasoseptal flap. So using this technique, out of 42 patients, we've had a leak, approximately leak rate of 2.4%. Here's the view of that meningioma case. You can see fascia lata, alloderm, and then the nasoseptal flap. And here's the delayed healing. But we've recently modified this technique of how to extend the flap, how to maximize the reach as well as the surface area. So if you look at this diagram, if you try to stretch this flap, there's going to be tension on this part of the flap. And this flap covers nothing of the skull base. This flap bridges the sphenoid sinus, and it's virtually useless. So we developed this technique where if you make a little relaxing incision, this allows the flap to extend the reach up towards the posterior table of the frontal sinus. And then with this redundant portion of the flap, you can rotate it posteriorly to provide coverage over the planum sphenoidale. And this has been very successful. I will demonstrate that technique in this medium-sized meningioma that we did endonasally. So for the sake of time, this is just drilling of the cribriform plate, drilling out the fovea ethmoidalis, crista galli. Can we mute the microphones, please?
Yes.
Thank you. So we'll devascularize the tumor, and then we'll make the dural opening much like we did in the sinonasal case. Debulking the tumor with a transnasal tip ultrasonic aspirator. And once the tumor is debulked, you can start to come around the tumor circumferentially using the CSF pulsations to deliver the tumor and using cottonoid patties to separate the tumor. This is much like doing a convexity meningioma, but from a trap door from below. And here's the final view. This is the tumor has been removed. We'll put it with some Surgicel. And if the defect is not too big, instead of using fascia lata as the first layer, I'll use alloderm as the first layer inlay with Surgicel. And here is the flap. So watch how we pull the flap. Look how it retracts posteriorly. So now we're going to hold the flap across the sphenoidal sinus, and then we'll make an oblique relaxing incision. And you have to make these incisions in an incremental fashion. But notice how the reach is now, the tension is now relieved, and that posterior flap we can rotate along the planum sphenoidale and get this nice coverage of the skull base. So that's the relaxing sphenoidal slit incision. Limitations of EEA, there's a higher risk of CSF leak, of course, and of course lateral extension, I think, is a contraindication, and hydrocephalus. So a tumor like this, I think, wide extension across the orbits, it's very easy to address with a standard open approach. I favor a transbasal approach because I have equal access to both frontal lobes and the cribriform plate. So if this ever extends into the nasal cavity, it's easier to go into the nasal cavity from a midline approach as opposed to a pterional approach. And there's minimal manipulation of the frontal lobes, and you have great access to the tumor. Right, this tumor actually invaded into the ethmoid cavities that you see here. Complete removal, and he was neurologically intact. This tumor goes almost from convexity to convexity. This is very favorable for open approach, complete removal. This was a grade 2 meningioma, and 24 cases transbasal. You rarely get a CSF leak. So I think the role of EEA for olfactory groove remains very limited and controversial, This is a recent systematic review showing that the results of transcranial are much better than endonasal in terms of gross total resection, lower rate of CSF leak, and in some cases, you might be able to preserve olfaction. So we reviewed our own series of olfactory groove meningiomas. This was recently published several years ago. And what we found was that our transbasal results were much better, the open approach. We had lower CSF leak rate, and the complete removal rate was lower, and but the near total, if you put it together, was high. And that's because I'm a little bit more conservative. If there's tumor adherence to a vascular structure or optic nerve, I will leave a little small residual. And we actually had 66% olfactory preservation. The complication rates were low for the transbasal approach, but when you add an endonasal corridor in a combined approach or pure EEA, we had one case of CSF leak with an infection and one case of pneumocephalus and frontal sinusitis. So, and if you compare it to the systematic review, the results are very comparable, favoring a transbasal approach. So you must know your limitations for endonasal approach. So if you have a large sinonasal cancer like this with significant intracranial extension, we favor a combined open and endonasal approach. This is a case of a teratocarcinosarcoma. You can see a lot of frontal lobe invasion, very easy to treat with a transbasal approach. You can dissect the tumor from the frontal lobe, chase it into the nasal cavity. We could seal off the closure. Here's the open nasal cavity. The tumor has been completely removed. And then you can use what we call a double flap technique, where you can repair this large defect with a pericranial flap from above and then use a nasal septal flap from below. You cannot always do this with a sinonasal cancer because sometimes the cancer can invade the nasal septal flap as well. So here's the double flap repair, pericranium from above, nasal septal flap from below. Here's a complete removal with a double flap repair technique. Here's another example. This was an atypical meningioma, aggressive meningioma recurrence, combined approach. And I'm going to move to the next presentation real quickly. These PowerPoints have a 4 GB limitation, so they'll crash. So I had to separate this presentation into 2 parts. Can everyone see my new screen now?
Yes, it's very clear, Professor.
It's this is transclival. You can see that?
Yes, of course.
Okay, good. So let me finish the remainder of my talk with the transclival and infratemporal fossa. So this is the transclival corridor. You can see all the many structures that you must transgress to get to the clivus. Traditionally, we've approached these with transfacial techniques, sometimes with disarticulation of the facial bones. But with endonasal technique, we've rarely had to use these approaches now because we have a nice panoramic view of the entire clivus and the brainstem and the craniocervical junction. You must remember where the course of the 6th nerve is because this can be injured during your drilling and dissection. And so here's a case example of a chordoma in a child. Chordomas have a classic T2 appearance, and they also have what's called a cortical thumbing sign, which is a little indentation into the pons. This is very classic. Now this chordoma was hidden behind a bed of rock. So this is the normal clivus. There's no soft tumor eroding the clivus, but retroclival, the tumor is all behind this area. So we have to use careful drilling with CT stealth image guidance before we can get to this soft gelatinous tumor. Now in chordomas, there's 2 layers of dura. There's the there's the periosteal layer of dura, which is the outer layer. And then there's an inner layer, which is a meningeal layer of dura. And here we're peeling off the outer periosteal layer. Now I know some of my colleagues are more aggressive in removing both layers of dura. In this case, I was a little bit more conservative. I decided to not get a huge CSF leak. So I preserved the meningeal layer of dura, and then that way there was no CSF leak, and I just repaired this with alloderm patch. And she had a nice decompression, nice removal. There was a little bit of residual in the Petrous Apex that we treated with proton beam. There was some recurrence about 4 years later, and we just went back and removed these small recurrences. This, however, is a case of a chordoma that was invading the right cavernous sinus. The patient had ophthalmoplegia from right cavernous invasion. But look at this. This is another area of cortical thumbing on the MRI scan. So we do a wide sphenoidotomy. And after doing a wide sphenoidotomy, we can start to access the tumor. You can use the mucosa off of the sphenoid sinus as a surgical handle to hold the nests of the chordoma cells to peel the tumor off. And now we'll follow the tumor into the cavernous sinus. Sometimes the tumor creates a corridor or avenue for you, and it takes you to the cavernous sinus. So carefully dissect the tumor from there. And what we'll do now is we'll follow the tumor, and this tumor invades into the dura. So naturally it takes us intradurally. There's the basilar artery. And so we'll cut out the clivus dura in a rectangular fashion, being careful to look for the sixth nerve. There's the dural attachment that's being removed, and there's the basilar artery. Here's the sixth nerve. There's the basilar artery. And there's the other sixth nerve on the other side. We'll repair this with a fascia lata, a fat graft, and a nasal septal flap, and a lumbar drain for 5 days. So this is a complete removal, went on to have proton beam radiation therapy. Here's another chordoma case, recurrence. This was treated initially by an ENT surgeon, but did not get radiation therapy. But now it's recurred within about 2 years. But look at the anterior longitudinal ligament for all the spine surgeons in the audience. This is chordoma seeding, these white dots. So this is a challenge. How do you get to this approach? It looks a little bit too low for endonasal. Maybe we go transoral. Maybe we have to split the tongue or split the mandible to get to this part of the spine. How do we do this? Well, maybe we don't have to use one single approach, but maybe we can use 3 different approaches in their respective corridors. This is a multi-corridor approach. We do an endoscopic assisted transcervical, like an ACDF. We get down to the longitudinal ligament, and we can take off the seeding pearls that were on the ALL. Here are those pearls of tumor seeding. Now we'll look transorally. We'll look also endonasally. So endonasally gives us the superior control of the tumor border, and majority of this is removed through the transoral corridor. So at the end, we can look at our suction, put the suction through the nostril and put the camera through the transoral corridor. You can see we have control of the top, control of the bottom, and get a complete removal. And then this time send the patient to proton beam radiation therapy to get proper treatment. And he's done quite well since then. Here's a patient with a jugular foramen syndrome. He's got 9, 10, 11, 12 palsies. Look at the winging of the scapula, atrophy of the tongue. This is lower cranial nerve palsies. This tumor was in the lower clivus, but also in the jugular foramen and parapharyngeal space. So in this case, I did not feel that this was a good approach for endonasal. So you must use an open approach to the jugular foramen. This is the infralabyrinthine transjugular approach that we use for glomus tumors. And so we can apply this to chordomas that invade the jugular foramen. So we'll do a infralabyrinthine mastoidectomy, skeletonize the sigmoid sinus. Here's the tumor that's invaded into the occipital condyle. The whole condyle has been eroded by tumor. We'll skeletonize the V3 segment of the vertebral artery in preparation for potential transposition. This is the fallopian bridge technique, sparing the bone over the facial nerve at the mastoid segment. And so we'll tie off the internal jugular vein and open up the sigmoid sinus. I like to do an intraluminal occlusion of the sigmoid using a gel foam, and then I inject Surgiflow distally to prevent back bleeding from the inferior petrosal sinus. I can then open up the sigmoid wall to get into the jugular bulb. This is the tumor that's in the jugular bulb. And we'll remove that tumor. And now we'll address the tumor in the paropharyngeal space. We've retracted the carotid arteries laterally, and we'll debulk the tumor using a tumor aspirator and excise it up to the jugular foramen. We'll excise the entire jugular vein. This is already occluded. And then we'll drill off the rest of the occipital condyle. Look how loose the joint is. And it's filled all by tumor behind this eggshell of bone. And we'll follow it to the clivus. So now we're able to drill the mid to lower clivus through this wide corridor that the tumor has given us. Now we can see the tip of the odontoid process. Here's the tip of the odontoid. We can now drill the tip of the odontoid, and I realized I didn't have to transpose the vertebral artery. We'll now go intradural and peel the tumor away from the brainstem. Here's the vertebral artery, ipsilateral vertebral artery, tumor in front in the prepontine area. These are the lower cranial nerves. These are already invaded by the tumor and are not functional. So we can divide them, debulk the tumor, and then resect the clival dura. So this is a VB junction brainstem, nicely visualized, large dural defect. I repaired this with an alloderm inlay, some Surgicel, and a fat graft. You have to seal off the middle ear so you don't get CSF into the middle ear, and a fat graft and a Medpore plate to put pressure on the fat graft. So here's the pre-op, here's the post-op, complete removal. We come back second stage with a occipital cervical stabilization of the spine, and he's done very well neurologically at his baseline stable. So can we do surgery through the nose, spine surgery through the nose, that is? And the answer is, of course. This is the rare case of endonasal surgery through the spine when we treat basilar invagination. Traditionally, this was done through transoral approach, but now we can do these endonasally. This is a case where the tumor is, this is a case of clipophile where the C1 is assimilated to the clivus. So you must be aware of this. So you have to open, I like to open up the sphenoid sinus and then follow the floor of the sphenoid sinus down the clivus so I can find the basion. I then drill off the C1 that's attached to the clivus. I drill a little bit of the clivus, and this gives you access to the odontoid. So understand that there's always some pannus tissue between C1 and C2. So you have to remove this pannus tissue right here and remove it so you can define the edges of the odontoid. Once you identify the edges of the odontoid, you hollow it out like a canoe. So you drill out the inside of it, leaving the eggshell thinness of bone, and then you outfracture it with an up-angled curette. So you want to not use a kerrison because until it's decompressed, because you could cause compression on the cord. But what you want to see is the reinflation of the dura, the dural sac. And once you see this reinflation of it, you are confident that you've done an adequate decompression. And hopefully in the absence of CSF leak, the repair is easy. I just put a little gel foam and Surgicel and some fibrin glue, and you don't have to close the mucosa. I know some colleagues that like to form a closure of the mucosa. This area mucosalizes very fast. And so in the absence of a leak, you can leave this with just gel foam. Here's the decompression. You can see the cord is nicely decompressed. Here's another few examples of basilar invagination. This patient had this cobra-like shape of the brainstem with platybasia compression. Good decompression here. Here's another example. Look at the cord injury from this chronic injury of this compression. Here's the decompression. And when you stabilize them and fuse them, you can actually restore the height of their platybasia to help decompress them. This was a dramatic example in a child who had this indentation of the brainstem. And look at the syrinx. This was an entire syrinx that went all the way down to the thoracolumbar junction. But when you decompress them, notice how the syrinx completely resolves. And she also had preoperative scoliosis. So when you treat these patients and reverse their syrinx, you also reverse their scoliosis if it's caught earlier in time. So we'll talk about the last corridor, which is the infratemporal fossa and Petrous Apex. You can get into the cavernous sinus lateral to the carotid artery and Meckel's cave. So this is a dermoid cyst here in the Meckel's cave, and see how it presents to the sphenoid sinus. So in this case, you can do a front door access to Meckel's cave. It's done through a endonasal transpterygoid approach. So you do a wide sphenoidotomy. We open up the bone over the area of the tumor that presents itself to the sphenoid sinus. So we'll drill the lateral sphenoid wall and the top of the pterygoid to get this wide sphenoid access. This is very similar to doing a lateral sphenoid encephalocele. You have to open up widely. Sometimes you have to move the contents of the pterygopalatine fossa laterally. But we open up the periosteum, and here you can see this is the dermoid contents. This is the sebaceous glands and the keratin debris that you classically see in a dermoid cyst. So we'll debulk all of these contents. There's a piece of calcium here. That's a piece of rock inside Meckel's cave. And so we'll take the remainder of this portion, and then we could drill down this area of calcium to get better visualization and access around the corner of this piece of rock. And so we can look all the way back here, and there was a communication of CSF into this area of Meckel's cave, most likely from the trigeminal cisterns. Here you can see a little bit of CSF. So we'll pack this area with a fat graft and then repair this with a nasoseptal flap. So this is front door to Meckel's cave. Here's the post-op scan. For this trigeminal schwannoma, you can also consider the front door to Meckel's cave, because if you look at the tumor, it presents itself nicely to the back of the sphenoid sinus. Here's the tumor periosteal layer. And then we open up the dura, and then we can work on the tumor, debulk it, and remove it. And then here's the paraclival ICA. We use 6th nerve monitoring. We can stimulate the 6th nerve here. And then this was a nice complete removal for this trigeminal schwannoma. However, when the trigeminal schwannomas are larger and have this dumbbell-shaped appearance with brainstem compression, this did not have a good presentation to the sphenoid sinus. So this makes no sense to do endonasal, very dangerous and probably very foolish. So you must know your open approaches. Which open approach would you do for this? Well, for me, I decided to do a Kawasi's approach with a transzygomatic variation. You do a T-bone cut on the zygomatic arch to drop down the temporalis muscle, and you elevate the dura to look for the Fukushima rhomboid. This is bordered by V3, GSPN, and arcuate eminence. You do your anterior petrosectomy, preserve GSPN, and we can now open up the posterior fossa dura, open up the middle fossa dura, and then cut the tentorium after you ligate the superior petrosal sinus. Cut the tentorium to the free edge, and then you can open up the fibrous ring of the porous trigeminus to get into Meckel's cave. We debulk the tumor with an ultrasonic aspirator. You can work above and below the 5th nerve. Here's the brainstem, the pons being decompressed. And then here's the tumor being separated. You must identify the nerve fascicles that it's arising from so you can preserve the majority of the trigeminal nerve. We'll debulk the tumor and then carefully roll the tumor. This tumor extends right into the back of Meckel's cave. And so here's the last bit of tumor. This is the brainstem. We've preserved the trigeminal nerve here. Here's the nerve going into Meckel's cave. And this was a complete removal post-op. And the patient did very well, was neurologically intact with the exception of a little bit of facial numbness in V2. And then moving on to the Petrous Apex. This is the area of the Petrous Apex medial to the paraclival carotid. Typically, you can see cholesterol granulomas in this area. Here's a big Petrous Apex cholesterol granuloma. Using this window that's medial to the paraclival carotid, we'll drill the infracellular clivus bone. And when you're drilling the clivus, beware not to violate the prepontine dura because you can get CSF leak. But here we can open up the cyst wall. Here's the cyst wall and the Petrous Apex contents. This is the cholesterol granuloma cysts. And then we'll use an angled 30-degree endoscope. You want to maximize this fenestration to minimize the recurrence. So we'll drill off more bone and then trim the cyst wall using a microdebrider. And then we can irrigate this using an angled suction hooked up to a syringe. We'll irrigate all these contents using irrigation. And then we'll use a 30-degree angled endoscope to look inside the cyst wall. Here's the cyst wall. And then to keep this opening patent long-term, we use a nasoseptal flap. You don't have to use a big one. You have to trim it, tailor it, make it a small flap so that it just goes just inside the cavity. And what this does is it allows early mucosalization of the cyst wall and it forms a marsupialization. Then we'll roll up a silastic sheet like a cigarette. And then when we put it inside this cavity, it'll open up and recoil and it will put pressure on the flap. So the flap will heal. Now this stent usually stays in for about 14 days and the ENT colleagues can take it out. But the result is this: you get a nice long-term patent hole that drains the cholesterol cyst. And when you come into the office, you can see there's a nice mucosalization of this cyst wall. And this has been patent for the last 6 or 7 years. A very nice result. And this has changed the way we've done cholesterol granulomas. Now, not all cholesterol granulomas are favorable for open approach. You have to study the anatomy. This is a large cyst, and if you look at the paraclival ICA and you look at the prepontine CSF cistern, there's not much room for entering this area. So in this case, we decided to do a variation of Dr. Delashaw's technique, my mentor, who used to put a catheter into the cyst and then drill a hole between V1 and V3, which takes you to the sphenoid sinus, and it drains the catheter into the sphenoid sinus. In this situation, the patient had mastoid disease, and working with my otology partner, we did a combined parapetrosal transmastoid middle fossa approach. So we do the Delashaw catheter from the cyst into V1 and V2 into the sphenoid sinus, but we also put a catheter from the cyst into the mastoid cavity where it can drain into the middle ear and out the eustachian tube. So we call this the dual exhaust drainage. And he has been recurrence-free now for 7 years. Actually, I'm sorry, 10 years now. He's been recurrence-free, and this has been a nice technique to drain the cyst. You don't have to resect every bit of the cyst wall. This is a mistake because you will have higher risk of complication. And lastly, my last topic is infratemporal fossa. We see large JNA tumors like this patient, this young boy, who was having trouble breathing, but also losing weight because he couldn't eat from this large tumor. So we can apply different corridors, and this is a transeptal corridor where we preserve the mucosa. So if you make a trap door, you can suture this mucosa back and preserve the integrity of the nasal septum. But then this allows you to use binostril technique. You can put an instrument to help you using two-handed approaches. We typically will do preoperative embolization before surgery for these vascular tumors, but you also have to devascularize the maxillary artery that you saw there. And then once it's devascularized, you can debulk it with a microdebrider and then start to peel the tumor away from the skull base. This tumor here is invading into the inferior orbital fissure. This is the fat that you see there. So you have to follow the contour of the tumor. It will invade into little nooks and crannies of the bone. So make sure you follow the course of the tumor so you don't leave tumor residual behind. And again, once the tumor is devascularized, it's easy to debulk it with an ultrasonic aspirator. And this tumor was very large. It had a nasal component and a nasopharyngeal component in the back of the nasopharynx. So the tumor was quite large, so we cut it in half. So we removed the upper portion through the nasal cavity, and then the lower portion was too large to remove through the nose. So instead, we're going to push the tumor down through the oral cavity, grab it with the tongs from the oral cavity. This is the tongue, and then deliver it through the transoral corridor. So notice how this large tumor was very difficult to remove through a small nostril. It's better to just easy to push it down and remove it through the mouth. And here's the postoperative scan, complete removal. Now, in a larger tumor like this with multiple compartments into the cavernous sinus, I think it's safer to do a combined multi-portal approach. The idea here is that we use the transcranial approach to get control of the cavernous ICA. Because if you try to do this purely through the nose, the cavernous ICA is the last structure you're going to see, and you don't have early control of it, and you can get an injury. So the idea here is to do an FTOZ extradural approach. You peel the lateral wall off the cavernous sinus to expose V1, V2, V3. We can open up the anteromedial triangle periosteum and identify the tumor. And here, we're peeling the tumor away from V1, away from the cavernous ICA. Here we're opening up the tumor between V2 and V3, and we're pushing the tumor into the infratemporal fossa. Now we do the rest of it from below. We're going to add another corridor, which I think is a very useful corridor for laterally extending tumors. It's a sublabial Caldwell-Luck corridor, and this gives you an extra portal for an extra hand or instrument so that you're not working purely in the nostrils. So by adding the sublabial corridor, you have an increased degree of surgical freedom. And we can now, again, remove the tumor in compartments. We'll remove the medial nasal cavity component first. Now we can turn our attention towards the lateral component. This is the component that's in the infratemporal fossa. Here we're separating the tumor from V2. We're going to separate the tumor from the buccal cavity. This tumor eroded through the hard palate, so we're lifting the tumor up. There's some vascular feeders from below. We'll coagulate and divide them, and then remove the rest of the tumor through the Caldwell-Luck maxillotomy. This is the temporal lobe dura, middle fossa dura. There's V2, sphenoid sinus here, infratemporal fossa cavity. Complete removal, and the patient was neurologically intact, just a little bit of V2 numbness. Here's a infratemporal fossa meningioma. This is radiation-induced meningioma from childhood leukemia. This is involving clinoidal ICA, Petrous ICA. So we add the Caldwell-Luck corridor. This is a 3 corridors technique. Here's the Caldwell-Luck maxillotomy. Here we're drilling the bone off of the posterior wall of the maxillary sinus. We'll open up the sphenoid sinus. And then using a caudal elevator, it's a very useful tool for these tumors. We'll peel the tumor away and separate the periosteum layer of the dura from the tumor capsule. We use a microdoppler to localize the clinoidal ICA so we avoid the injury. And then we could use the curved angled suction and also angled endoscope to tumor debulk and to remove the tumor off of that middle fossa dura. So here we're separating the tumor from the cavernous ICA periosteum, separating it from the periosteum down low. And then we'll resect the tumor in the middle fossa using an angled curved suction and an angled endoscope. This is the middle fossa dura. Here I decided not to resect the dura, to do a Simpson grade 2 resection. We'll coagulate the dura just to avoid a big dural defect. She did have a small little defect here that we repaired using an alloderm plugging technique, and then using a nasal septal flap from the contralateral side, reaching to cover the skull base, and then inspecting from maxillary sinus to maxillary sinus, panoramic view of the skull base. And this was a grade 2, Simpson grade 2 removal, and she left on postoperative day 2. Here's the last tumor. This is a schwannoma, infratemporal schwannoma. Again, this was tricorridor, adding the Caldwell lock maxillotomy, complete removal. So I'll conclude with these thoughts. This is my philosophy. The endoscope is just a tool, and it's just a tool in the armamentarium for the skull-based surgeon. We have to remember that patient selection is very important for success, and that not all patients or not all pathologies are optimal for endonasal approach. We have to be tailors and tailor our approach to each individual patient. This is, I don't know if you know this person, this is Bo Jackson. He was a professional athlete in the USA, and he played 2 sports. He was a professional football player and a professional baseball player, and he was incredibly talented at both sports. And so I think the contemporary skull-based surgeon has to be like Bo Jackson and have expertise in both open and endoscopic techniques. And sometimes you have to apply both and use multi-corridor surgery strategies. Of course, teamwork, having a great team behind you is the key to success. And this is my team. I just want to acknowledge all our team members, my ENT colleagues, as well as my endocrine ophthalmology, interventional radiation colleagues. And I thank you for your attention.
Thank you very much, Dr. James. I guess it's a very amazing lecture. We learned a lot from you tonight. You delivered so many knowledge for us. It's amazing, like always in every lecture. So now, can we start to discussion and Q&A, Dr. James?
Sure. Should I stop sharing my screen or?
It's okay for you?
Yeah.
Yeah.
So this is my email. If you'd like to email me, you can contact me through social media on these media forums at Skullbase MD. So feel free to reach out to me. I'll stop sharing my screen and take questions from the moderator or the chat room.
Thank you for your kind heart to give us your contact, media social and everything. We start for discussion. Everybody who want to ask Dr. James can raise your hand, first from panelists and then after that from the participant. In this first time, who want to ask for Dr. James? I have a question for you, Dr. James, before the other panelists. Your lecture is very interesting. I saw your video about removing the tumor from the thalamus. You always say it against the temptation for pulling the tumor, right?
Yeah.
Yeah. How do we know that it's already we start to deliver the tumor instead to pull the tumor? How do we know that the right time to do that?
Mm-hmm. Yeah, that's a very good question. I think a lot of it, for me, it developed with increased experience to sort of know what you can do. Generally, when these craniopharyngiomas, I think one of the hardest parts is right at the back where it's stuck to the hypothalamus. And what I typically do is I use a suction dissection technique where you, with your right hand or your dominant hand, you put a little gentle traction on the tumor, and with the suction, you put your thumb, if you're using a Fukushima suction, I'm using like a 6 maybe 5 to 7 French suction, and you have to gauge how much power you use in the suction, but just enough to get rid of the blood. And then you use the tip of the suction and you're gently sweeping, and you're pushing the hypothalamus away from the tumor capsule, but you're staying right on the tumor capsule. So that's one method of dissecting that area. And I think that's a useful technique to separate that plane. Sometimes you see a little bit of this gelatinous material, and sometimes it's hard to differentiate whether this is part of the tumor or part of the neural structures. And that's always been an area that's been difficult for me. But I generally will leave a little bit of that jelly material on the brain and then monitor it. But I think you have to be very gentle with your dissection around the hypothalamus. You can't pull. You have to use gentle sweeping and gentle suction dissection to get that portion off.
Okay. Yeah, I keep it in mind. The second question is for the craniopharyngioma that you show in your video. Do you know how to sacrifice the stalk before the surgery, or depend on during the surgery? You have to cut the stalk.
I think that decision should always be made intraoperatively. I never make a decision that I'm going to cut the stalk before surgery. So I always tell the patient that we will try everything we can to preserve the stalk, but in some cases, the tumor already is invading the stalk and it's not possible to save it. So you always have to prepare your patients for the anticipation of hormone replacement therapy. Yeah. And you have to remind them that it's not the end of the world. A lot of patients live with hormone replacements. Mm-hmm. You know, the goal is to try to treat the tumor, but I always try to preserve the stalk, and the decision to save or sacrifice the stalk should be made on intraoperative observation. So if you feel that the tumor has invaded the stalk or it's blown up the stalk, and that you can get a gross total removal or a maximal near total, and the only way to do it is to release the base of the stalk, then you have to do it, because it doesn't make any sense to do a partial removal and you save the stalk and then the stalk doesn't work, and that's what Dr. Oldfield said. You know, that was in the quote. So if you can get a total removal and at the cost of the stalk, then sometimes you have to make that decision. But you saw the case that I showed where I knew intraoperatively I was not going to get a complete removal. But if I save the stalk, I can spare her pituitary function. So in that case, I decided to spare the stalk.
Okay. My last question is, I quite interesting about no nerve touch technique. Do you use a sharp tool for that, or you use blunt tool for the kind of technique?
Well, I tried to use sharp dissection as much as possible. The no-touch technique is more of a philosophy than it is a technique. It's basically try not to touch and manipulate the nerve. Mm-hmm. You know, sometimes you watch other videos, you can see there's too much optic nerve moving, and anytime you touch and move the optic nerve, they're very sensitive. You always, as a surgeon, you have this fear that the patient's going to wake up blind. So I try to touch the tumor, not the nerve. So move the tumor away from the nerve, and then I like to use that arachnoid knife. It's an Apex arachnoid knife, AM22. And you can cut the arachnoid or the fibrous bands right on the tumor capsule, and it releases those adhesive membranes so that those membranes fall towards the nerve, and then you can peel the tumor away from the nerve.
Okay, thank you. We have Dr. Renindra from Jakarta, from Universitas Indonesia. Yeah, you can ask Dr. James. Please, Dr. Renindra.
Thank you, Dr. Roland. Excellent presentation, Dr. Liu. And I have two questions. The first one is, how long does it take to adjust yourself? I mean, when you're doing the microscopic surgery, it's a 3D perspective, and the endoscopic is the 2D perspective. So how long you have to adjust that until you are comfortable to do both approaches? And my second question is, during the pandemic right now, what are your management with the patients that you have to do the transnasal approach, the preparation, and to be safe? Thank you.
Thank you for your questions, Dr. Renindra. I think for the first question is the adjustment. How do you make the adjustment from microsurgery to endonasal surgery? I think there's a number of things you can do. First of all is you have to be comfortable with your ergonomics. You know, you have to set up the screen so your body is not twisted. If you don't set up your screen properly and your body is twisted in a long hours, you're going to have self-injury. And there's actually literature on this in terms of surgical economics in other fields where we as doctors and physicians, we can suffer chronic injuries from bad positionings in surgery. This is not the patient position. This is our positioning, the way we sit, the way we stand, the way we position our bodies. So you want to have a long career, long successful career. So it's important to set up the screen. So I try to set up the screen so I'm looking directly forward and I have minimal, of course, there's some rotation of your body to get to the nostrils, but you don't want to be turning your head and leaning over long hours in a very uncomfortable position. So that's important. And then there's a learning curve with working with your ENT. So you're not constantly bumping into each other, into their instruments, because that can be very frustrating, because microsurgery is mostly a solo operation where you're flying solo and you're comfortable in your own zone. You don't have any hands that are obstructing your composition of music, so to speak. But when you're working in endonasal surgery, you have another set of hands. And when you're first working out, it can be frustrating when you're hitting your ENT's instruments or his instrument is bumping into yours, and that can be potentially dangerous. Because if you're working around the brainstem or an important artery and his scope hits your instrument and that instrument goes into the nerve or a vessel, then it's disastrous. So there is a learning curve. There is a learning curve in working together with your partner. So you have to develop that comfort. You have to develop that dance and understanding, and each of you can work those kinks out. And so it can take a number of cases. I don't know the exact number of cases. I think that varies with each individual and each individual team, but certainly you have to do probably at least 50 cases, maybe 50 pituitary tumors to develop some kind of comfort. And then once you start getting comfortable with extradural tumors like pituitaries or chordomas, then you want to move to the next level of transplanum corridor with craniopharyngiomas or meningiomas. And those are more, have a higher level of difficulty because now you have to deal with neurovascular structures, arachnoid dissection, and of course, repair of CSF leak. So I think you have to do this in a graduated fashion. In terms of the 3D perspective, as you start to do these surgeries, there's different cues that you can do. I generally will put the suction in a safe place in the skull base. And the safe place for me is the area under the cella, the infracellular clival recess. It's usually bone there. Be careful, there are paraclival carotid arteries there that you have to be careful. So don't put it on the carotids, because if the bone is thin, you can injure the carotid. But put your suction in the clival recess because you have a tactile feedback on that suction tip. So you kind of know the depth of your instrument. The other trick is, using dynamic mobilization of the endoscope. So if your colleague is holding the endoscope, they are moving it in and out. So you have an idea of the 3D perspective of the anatomy. And I think lastly is good knowledge of the anatomy. If you know the anatomy and you're always seeing the forest from the trees perspective with dynamic mobilization of the endoscope, as well as tactile feedback from the structures, I think you will naturally develop a three-dimensional sense of the anatomy, even though you're looking at a two-dimensional screen.
Thank you. And the second question about the pandemic, during the pandemic, what are the preparations to have a safe surgery?
So in our hospital, we generally do COVID testing within 72 hours of the procedure. If the patient is positive and it's a non-urgent surgery, then of course we'll try to delay and postpone the surgery. If it's an emergent or urgent surgery, then we have to take a lot of precautions. If it's endonasal surgery, then I wear an N95 mask, a face shield, maybe some goggles, and the highest risk I think is during drilling of the bone. So because that's what aerosolizes the particles. I think if you're able to minimize drilling, that's helpful. I know some groups have published some apparatuses in terms of special drapes or some kind of negative pressure environment where it minimizes displacement of the aerosolized particles. We don't have that in our hospital, so I don't know what the best solution is. I thought of maybe putting a towel around our hands while we're drilling, a wet towel over our hands. I don't know if that works, but it's just a thought. But certainly we're taking risks when we do these surgeries if they're COVID positive.
Thank you, Dr. Liu.
Thank you, Dr. Rendra. Is there somebody else want to ask Dr. James? I saw my friend here from Japan, Dr. Jumuto. Are you with us here now? Dr. Jumuto? Yes, hi, how are you?
Hi, Jun, how are you? Good to see you.
Hello, good to see you, Dr. Jumuto. Yeah, you have a question for Dr. James, right?
Yeah, so thank you for nice presentation. So I'd like to ask you about closure. So you said just that you use allodam, right?
It depends on what type of approach.
Yeah.
So transplanum, I use autologous fascia lata, and transclival, I use fascia lata, but transcribiform, if the defect is not too big, I just use alloderm, so I spare them a big incision on the leg.
Yeah. So how about the Duragen? So we cannot use the allodam in Japan. So Duragen. Duragen,
I just use Duragen as an inlay, but I don't trust Duragen because I think it's collagen based, and I think it dissolves very easily, so it's not very strong. So I'm not a big fan. If I use Duragen, I probably will use fascia lata also.
Yeah, I agree with you. So in Japan, we just start to use Duragen for 2 months, but I think the Padjadjaran is better than Duragen.
Yeah.
Thank you.
Thank you.
Thank you, Dr. Junmuto. And yeah, Dr. Hadi, you can ask the question for Dr. James.
Okay, thank you. Nice presentation, Professor. I continue ask about the close the defect. Some paper presentation about the PET to close PET for the close the defect. How about your opinion about this PET?
PET.
Yes.
About the fat, right?
Yes.
The fat.
Yes. Okay.
The question is, do I use fat graft for closure?
Yes.
Okay. So I rarely use fat. You're talking about endonasal Skullbase or open Skullbase?
Endoscopic.
Endoscopic. So
yes.
The only time I use the fat is chordoma cases, because when the fat helps prevent the pons from herniating through the clivus. the Pittsburgh group had published a paper about reduction of the pontine encephaloceles. So I like to put the fascia lata. I use a Duragen inlay, and then a fascia lata over the dural defect, and then I put the fat in the bony clivus defect, and then the nasoseptal flap last. That way, the nasoseptal flap doesn't have to reach all the way down to the defect. It can be right on the surface of the bony clivus defect.
Okay.
The other time I use fat is in sometimes you have these pituitary cysts that communicate with the CSF cistern. I think these are communicating Rathke's cleft cyst. You open up the cyst and there's a clear communication of CSF into the cyst. I will pack those off with fat and then a nasoseptal flap.
Okay, sir. Thank you.
Thank you, Dr. Hadi. First, Dr. Irwan, and then Dr. Arwin. Okay.
Thank you. Nice to meet you, Professor James. Very nice presentation. My question is about the position of the operation. You explained me that the position is on the scope is on the 6 o'clock, right?
Mm-hmm.
What is it is different between the preformis, clivus or transplanum? Is it same position or different? Thank you.
Oh, that's a good question. So the question is where to position the 30-degree endoscope, depending on the corridor. I think so anything looking up, like transcribiform or transplanum, in most cases, the endoscope is 6 o'clock looking up and your instrument's at 12 o'clock. For pituitary surgeries, sometimes we change back and forth. Sometimes I will work standard in the 6 o'clock position, but when we have to look up to get the tumor that's extending upwards, then I switch so that the endoscope's at the 12 o'clock and my suction is at 12 o'clock and the endoscope's at 6 o'clock. And then transclival, you're looking downwards mostly, you're looking downwards. So in those cases, I will work in the standard position, which is in the 6 o'clock position. But sometimes you change, sometimes you say, okay, I think I need to look over here. So you're always changing. So you have to be able to adapt and change position to what you need to look at. So it's not always a fixed rule, but as long as you understand the concept, you will know how to apply the concept when it's necessary.
Okay. Thank you, Professor. What about the 0-degree endoscope? Do you also use for that?
Yeah, sometimes we'll use the 0-degree because you'll find that the 0-degree is more favorable because sometimes the anatomy is different for every patient. So sometimes we're doing a pituitary tumor and my ENT colleague likes to use the 30-degree scope. So when I'm looking downwards, it's too far down. And when I look upwards, it's too far up. So that's when I know 0-degree is probably better. So we switch to a 0, do the tumor. And then if I want to look extended, then I will change to a 30-degree to look around.
So you combine between 0 and 30-degree.
Yeah.
Okay. Thank you for the answer.
Thank you, Dr. Irwan. And now, Dr. Arwin, you can ask Dr. James.
Thank you, Dr. Roland. Great presentation, Professor. I would like to ask you one question regarding infratemporal fossa. Which type of approach would you prefer? I mean, how do you decide preoperatively that this is enough through the nose, or should I go transmaxillary, or like the one you presented the last case through the Cardwell loop? What is that you see in the preoperative MRIs of these patients that would decide your choice of approach? Thank you.
That's a great question. Let me, whoops, 1 second here. So there was a paper written by Andrew Little at the BNI, and he talked about what's called the send line. And I'm just going to show you a slide here if I can figure out how to share my screen again. 1 second. Can you see this?
Yes, very clear.
Okay, so Dr. Little at the BNI published this paper called the send line, and this line you draw from the nasal tip at the nasal septum, and you draw it through the nasal lacrimal duct right here on the scan. And if you draw this line and there is significant tumor lateral to it, then adding Caldwell Luck can make your life a little bit easier. Now, certainly you can do this all endonasal. I've done a lot of these tumors endonasal, so this is not an absolute rule, but I think this gives you an idea of what you're comfortable with. So always remember what you're comfortable with. Now, in the case I showed you with the massive schwannoma or the massive meningioma, it's more comfortable to add another corridor than to work binostril, because those tumors went all the way to the lateral compartment of the infratemporal fossa, all the way to the lateral maxillary wall. So it's very awkward to work purely in the nose. Some people have described using a Denker's maxillectomy, and I'm against using a Denker's maxillectomy because this is where you remove the bone off of the lateral nasal piriform aperture. Those can result in more cosmetic defects where you have a sunken defect because you lose the bone here. So I think from a cosmetic standpoint, and also by sparing the nasal lacrimal duct, it's easier to come in under the lip, and it's very tolerated by the patient, and I think it makes life easier for the surgeon.
All right. Thank you, Professor.
Okay. Is there any? Okay. For waiting for any question. I read the question from the participant. Oh, yeah, Dr. Selfy, you want to ask something? No?
Yes, Dr. Roland, thank you very much.
Please.
Thank you, Dr. Liu, for the excellent presentation. I just have a couple of small questions. My first question would be, when you're doing the transclival approach, what would you use for the landmark for the sixth nerve besides using the intraoperative monitoring, the stimulation? And also, my second question would be, is it possible to spare the olfaction for the transplanum, transtuberculum approach, and how to do that? Thank you.
So the sixth nerve in the transclival, I don't think there's a constant landmark, but you do have to look for it as you're drilling the clivus, because there'll be a ridge of bone where the Dorello's canal forms. I don't think there's a good constant landmark to identify it, but I think that's something that would be worth studying in the laboratory. I think certainly finding it cisternally, intradurally is always helpful. But when you're drilling, you have to be very careful when you're drilling, and always look for it behind that paraclival carotid. Certainly using sixth nerve monitoring in those cases is helpful with neuromonitoring. And then the other question was, can you remind me the other question?
Sorry, to spare the olfaction.
Oh, spare the olfaction, yeah. So I think you can lose olfaction in transplanum approaches, and it's not violation of the olfactory tracts or olfactory bulbs that you get in transcribiform, but I think it has to do with your mucosa, the superior olfactory mucosa in the approach. So one thing you can do is you can make an incision like you do in pituitary surgery, cut the superior olfactory strip, and then flap it upwards like this. And then you have to be careful of how much tissue you take when you're debulking the soft tissues. So I think if you can spare the superior olfactory strips, you have a higher chance of preserving the olfaction.
Thank you, Dr. Lee.
Okay, thank you, Dr. Selfy. Now I read some of questions from the participant. Some question already asked by panelists, but I read that question from Dr. Krishna, is from Indonesia, I guess. Dear Professor, I saw in your video you use plastic working channel inserted to the nostril, but some video didn't have it. Do you use routinely or may use in special occasion for that plastic working channel?
So yeah, I was experimenting with this plastic working channel because, as you know, this Dr. Snyderman developed this silastic channel. I forgot the name of the company, but there's this channel that you can put in the nose that opens up like a port to help protect the soft tissues in the nose. And it helps prevent the blood from getting on your camera of the endoscope. And, in my hospital, I work in a urban hospital funded by the state. So in terms of resources and acquiring new technologies, it can be a little bit challenging. So I tried to come up with a solution, a cheaper way of simulating this channel by taking a silastic sheet, which our hospital already has, and then I roll it up and then I suture it together so it forms a tube, and then I can put that in the nose. And it helps, I think, in keeping the field dry so you don't have blood running down on the camera. I don't use it all the time. So if it's a quick pituitary case, I don't use it. But if I'm having trouble and there's a lot of bleeding, maybe the patient's nasal mucosa is more vascular, or there's just a lot of bleeding that's very annoying to deal with, then I'll use that in those cases. So some company already made it, or you made? Well, the one that I use is just a sheet of it's by Medtronic, but it's just a sheet of silastic and you just roll it up and you suture it together like a cigarette, like a tube. But there is a tube that's already made, and it's made by a company that Dr. Snyderman from Pittsburgh developed, and I'm trying to remember.
Spyway, I guess.
Spyway, yes. Spyway. Have you used it?
No, I just saw it, but I don't think it's already, used outside US, I guess.
Yeah. So this is my contribution to global neurosurgery, is not everyone has access to these fancy toys.
Yes.
So
Right.
maybe if your hospital has a little plastic or silastic, you can think outside the box and just suture it together and make a tube and then put it in the nose.
Very interesting. Next question is from Dr. Bintang. Do you prefer always binostrial in every EEA? Or sometimes uninostril?
Yeah, I prefer binostril for most EEAs because I like more room to work. It's more comfortable, doing microsurgery. There are a few instances where we do use uninostril EEA, and I would say that's for when you're treating perhaps a unilateral pterygopalatine fossa schwannoma. That's one of the few instances I can remember. But if you need more room, you can make a window in the septum. It's a mucosal sparing septectomy. You can cut the mucosa on both sides, cut a window of the cartilaginous septum, and then work by nostril if you're working in the pterygopalatine fossa. And then you could suture that mucosa back together.
Okay. And next question is from Dr. Weil Alabas. I hope you pronounce your name right. In what case do you use posterior petrosectomy in case of retrochiasmatic instead of endoscopic approach?
Okay, that's a great question. The approach that you're referring to is an approach that was popularized by Professor Hakuba and later by Professor Ohata, who does the posterior petrosectomy for retrochiasmatic craniopharyngioma. I have not had experience using that approach for that tumor. Certainly, my colleagues from Japan have large experience with doing that. I personally use that approach mostly for petroclival meningiomas and giant trigeminal schwannomas. But I don't like working in small corridors because in that approach, sometimes you have to divide and ligate the PCOM. And even though you can preserve the PCOM perforators and avoid a stroke, there can be risk of a stroke whenever you cut the PCOM. And you have to work between nerves and vessels to get to the tumor. And I think it's going to be difficult to see the hypothalamus on both sides at the same time. But I think, in the endonasal approach for retrochiasmatic, I feel like the view is unmatched. To be able to see that whole panoramic view of the hypothalamus, the third ventricle, you have a symmetric view. Actually, look at the picture behind me. You cannot get this view that you get with a transpetrosal approach. Transpetrosal approach, you're looking from the back and you're looking from the side, and you have to look between the third nerve and the PCOM and the third nerve and the optic nerve. So coming in endonasal for retrochiasmatic, I think is unmatched. Okay. That's just my personal opinion.
Yeah. Thank you. Next question is from Dr. Diman Kauduri. Hope I pronounced right. In case of combined approach, what should be addressed first, transcranial or endonasal, or you do the both in the same time?
Okay, so I think this is pertaining to maybe a large esthesioneuroblastoma, big craniofacial tumor. I do these at the same time, and generally we position the patient, we prep the head, we prep the face, we prep the nose all at the same time. But surgically, I'll do the craniotomy first. So I do the bicoronal and I'll take out the tumor, and then I'll chase the tumor into the nose. So I'll remove as much tumor as I can. Of course, I have my ENT colleague will come from below, and he'll use the endoscope mostly to remove any remaining tumor or to inspect, and then to check for any invasion of tumor in the nasal cavity into the mucosa. And then I'll do the repair from above. I'll try to get a watertight closure of the frontal dura, and then rotate the pericranial flap. And from below, this is the double flap technique. If there's no invasion of the nasal septal mucosa, then we will use the nasal septal flap as a secondary supplemental flap from below. So those are done at the same sitting.
Yeah, thank you. Another question is from Dr. Petra Wahyu Pramono. Dr. James, in your case of transoral and transmenudal approach, do you involve your ENT surgeon always, or sometimes you do it alone?
So for the endoscopic approaches, we always involve our ENT colleagues. For transsphenoidal and transoral.
Always.
Oh yeah, almost always. Yeah.
Almost always. Okay,
Yeah.
thank you. Next two question is from Dr. Roberto Leal. Hello, Dr. Liu. You know those fibrous and hard tumors, and they are prevalent. If you still try to remove them from the endonasal approach, even there is adherence to carotid and nerve, they are not suckable. What your opinion?
So I always think we have to always think about preserving the quality of life of the patient. So obviously you want to avoid any nerve or vascular injury. And as an old friend once told me, it's better to leave tumor on the nerve or it's better to leave tumor on the vessel than to leave vessel on the tumor. So yeah, you want to avoid a carotid injury. So if it's stuck, then do your best to shave and to trim the tumor to do a maximal debulking and leave a residual. If it's a benign tumor, we can always treat benign tumors by monitoring them or radiosurgery. If it's a malignant tumor, then it depends on the tumor type. Then you have to plan this out earlier on with your team. But in most cases, we're dealing with benign pathology, so we have to keep in mind not to hurt the patient.
Yeah, thank you for the answer. And last question from the participant is from Dr. Erliano. Do you stitch the fascia lata during your EEA? Well, what's your opinion?
I personally don't. I know some of my Japanese colleagues will stitch the fascia. I think it's very elegant. I think if you do it in your practice, I think it can be helpful. I generally have not. I just make sure I lay it down and secure it with some Surgicel and of course the flap and then pressure. But I think there are some advantages if you can suture it. You take the time to develop, the comfort and efficiency of suturing it. I think the idea is to reduce a high flow leak into something that's close to or near to close watertight. Because the idea is that before you put the flap on, you want to make sure there's no pulsations of CSF. Because if you start to see pulsatility through your initial repair, the flap is most likely not going to work because there's too much pressure. So you want to make sure you have a good initial seal before rotating that flap.
Do you usually challenge the patient to see the pulsation of the CSF? Like
I generally don't. I don't like to do a Valsalva because I think it'll just push the graft out. Yeah. Dr. Roland,
I think you're muted.
I'm sorry. You hear my voice?
Yes, clearly.
Yeah. Thank you for the nice and very interesting discussion and answering the Q&A from the panelists and from the participant. And also, I think within 2 hours, we still do not feel it's enough to adding all the knowledge that you've given. Maybe we have an opportunity in the next future to at another time. But sorry that we are running out of time. We have to end this very interesting webinar. Before I close this webinar, do you have a word for us, Dr. James?
Again, I thank you for this wonderful opportunity to speak virtually in Indonesia. Hopefully, after COVID pandemic ends, maybe we can meet in person sometime at a future Congress or dissection course. But I thank you again for this kind invitation, and it's been a pleasure spending this morning with you.
Yes, thank you very much. Hopefully, yes, like you say, hopefully another occasion after this pandemic, you can meet personally and learn again from you, Dr. Liu. And we wish when the pandemic ends, our relationship between our institution can continue, whether we learn, observe your place, or is there any chance meet Indonesia, we will invite you here to visit Indonesia. Maybe go to Bali, yeah, beautiful island, and you will talk and share your expertise here. Once again, on behalf of our Department Neurosurgery, Universitas Padjadjaran, Hasan Sadikin, Bandung Hospital, Indonesia, and also Indonesian Neurosurgery Society, I say many thanks to you, Professor James Liu, for the opportunity you gave us all, and also for all participants, Indonesian all around the world. Thank you very much for joining us today. I hope all of us are always in good health and condition. Thank you, everyone, and have a good night for you all. Thank you, Dr. James. Thank you, everyone.
Thank you.
See you next time.
Okay,
Okay.
Thank you.
Thank you, Dr. Indra. Dr.
Thank
Joyus.
you.
Dr. Liu.
Thank you very much.
Thank you.
Bye.
Bye. Thank you.
Thank you. Good morning.
Thank you,
Dr.
Dr.
James.
Liu.
Thank you.
Good morning. Yeah.
Okay, good evening.
Morning.
Dr. Junmuto, thank you.
Okay.
Dr. Adi.
Thank you.
Thank you. Bye-bye all.
Bye.
Thank you. Nice to meet you all.
Sampai lain kali.
You all.
Next time.